So for this session, we're going to talk about immobilization of the lower limb above the knee. Now, classically this is for a mid-shaft tibia and fibula fracture, injuries of the knee, and sometimes injuries of the distal femur. So often these are injuries whereby the patient arrives to the department by ambulance. And in the ambulance, they'll be immobilized in such a device, a splint. So one thing to mention about the splint, you can get your x-rays through the splint. You do not need to remove the splint to assess the patient. You do not need to remove the splint to get your x-rays. Often these are unstable fractures, and removing the splint will actually cause quite a significant amount of pain and distress to the patient. So leave it until you are absolutely ready to put the patient in some form of definitive plaster. So the first thing we have to do is measure. Now, for an above-knee cast, we're going at about midway up the thigh. So from the knee to the greater tuberosity over here. And you want to be about halfway down there. So just essentially it works out to being over the main part of the belly of the rectus femoris. So if we start from about there, and then we can measure from the side. So that's 77. So often what happens to prevent having too long a stirrup, what we do is measure it on both sides. So we have stirrups coming from either side, and then also measuring from the back. Now, one of the things that you will notice is that particularly the thigh, it's not cylindrical, it's almost conical. So sometimes what happens is that as you're putting your straps across, you will have bare areas. So you've got to account for that. So you may need some extra strips of plaster available. So you have to always take that into account when you're preparing for an above-knee cast. So we've measured and we've cut. So we've got, rather than having one long stirrups going all the way around the leg, what we've got are two sets. So one going either side, one lateral, one medial, and then the longer slab going around the back. We've also got a little bit of extra plaster because, as we said before, often the thigh itself is more conical than cylindrical. So the first thing we need to do is move the leg. Okay? So often if there is an injury here, we'll need multiple people to support. So we're going to ask for pairs of hands over here, we're going to ask for pairs of hands over here, and we're going to lift the leg together, gently bending the knee. It needs to be bent at around 20 to 30 degrees, supporting. So from there we go. Okay. And often this is the most difficult job of all, because often you'll feel the tibia just moving against itself. Often this needs to be done in the resuscitation area. You may need further analgesia or even sedation for this. So I'm going to start proximally and work my way down. So start from the top of the thigh, all the way around. Okay, so once you get to the knee, you ask your assistant to gently move their hands up and down. That's it. And this way. Some people do a below knee and then extend it further up to above knee. That is reasonable if there's no other option or if you've got limited personnel, but particularly at the join, it can be a little bit unstable, so it's probably better to do it as a single rather than a there we go. So We're going to start with our stirrups. Again, hold, cross, this way. So feel for the patella. That's it. Down. This can be quite tiring for your assistant, so you have to be a little bit quick about this. The medial side. One of the things to notice is that when you're putting a plaster like this on, actually the plaster does absorb quite a bit of the water. So do make sure that you've got enough water in. So this is now going to start from right up here. So, okay, I can see and feel that there's a couple of areas that I need to put some extra. Often it becomes apparent much later. So there's a gap that I can feel developing on this side. Just pinch this. See a gap on this side. Just keep the knee and around 20 to 30 degrees. Good, that's holding there. That's holding there. Hold this down. So particularly for a long leg like this, we'd want to use about 8 or 10 ply. It will be quite heavy, but these are usually, nowadays, temporary arrangements. We no longer treat tibial fractures conservatively. And it is very much more towards internal fixation. So again, a lot of the textbooks, there's a whole lot of stuff about traction techniques for these fractures, and that's not really relevant anymore. So if I hold, I've got it. You just want to unroll for me. There we go. See on the toes. What's there? Okay. So, one of the things to always bear in mind, if you've got a lower limb break and you're concerned about the alignment, your second toe and your patella should always be pointing in the same direction. So if you feel the second toe there, you can palpate the patella over here. You can see that they are aligned. That's one of the ways you know that your reduction is adequate. So if you've got a fracture with rotational deformity, that's one of the things that you need to do to make sure that you're aligned. Okay? So usually we'd ask for a pillow underneath this, so the leg is elevated. You already see that it's fine. We can bring this down now. Okay. It's already beginning to solidify. Excellent. There we go. So that is an above knee cast.